Hello, everyone. The call will begin shortly. Also wanted to just say CDC is currently experiencing some Zoom issues. So we're aware that some participants are experiencing issues joining via Zoom, and we really apologize for the inconvenience. If you're unable to join live, a recording of the call will still be available within 30 days online. But please, if any of your colleagues are having issues joining, please pass that information along. Hi all, for those just joining, the webinar will begin in a minute. We're giving a little extra time to join. CDC is currently experiencing some issues with Zoom. If anyone is unable to join the recording live the call live, a recording will be available within 30 days online. Good afternoon, everyone. I'm Alexandra Wixon, and I work in the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of CDC's One Health office, I'm pleased to welcome you to the monthly Zoonoses and One Health update call on May 3rd, 2023. We do want to note that CDC is currently experiencing some Zoom issues, so we're aware that some people are having trouble joining. But if you are unable to join the call live today, a recording of the call will be available within 30 days on our website. Next slide, please. So although the content of this webinar is directed to veterinarians, physicians, epidemiologists, and related public health professionals in federal, state, and local positions, the CDC has no control over who participates. Therefore, please exercise discretion on sensitive content and material, as confidentiality cannot be guaranteed. Today's webinar is being recorded. If you have any objections, you may disconnect now. Links to resources from each presentation are available on our website at cdc.gov/onehealth/zohu/2023/may.html. Next slide. Today's presentations will address one or more of the following 5 objectives: identify an implication for human, animal, and environmental health, identify a One Health approach strategy for prevention of public health threats, identify a One Health approach strategy for detection of public health threats, identify a One Health approach strategy for responding to public health threats, and list 2 ways to improve collaborative practice across the public health care team. Next slide. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, as well as any use of unlabeled products or products under investigational use. CDC are planners, presenters, and their spouses or partners who wish to disclose that they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. The Planning Committee reviewed content to ensure there is no bias. The presentations will not include any discussion of the unlabeled use of a product or product under investigational use. CDC did not accept commercial support for this activity. Next slide. Instructions for receiving free continuing education are available at CDC's One Health ZOHU website. The course access code is ZOHU Webcast. To receive free CE for today's webcast, please complete the evaluation at cdc.gov/TCEO online by June 5th, 2023. A captioned video of today's webinar will be posted on our May ZOHU webpage within 30 days. To receive free CE for the web on demand video of today's webinar, complete the evaluation by June 6th, 2025. Next slide. Before we begin today's presentations, we'll share some news and updates. If you are not yet subscribed to the ZOHU newsletter, please sign up using the link at the top of the main ZOHU Call webpage. You can continue to find on CDC's website the latest COVID-19 guidance and resources for keeping people as well as animals safe and healthy. Next slide. There are several publications highlighted in today's newsletter, including a couple related to foodborne outbreaks. The first is titled An Overview of Foodborne Sample-Initiated Retrospective Outbreak Investigations and Interagency Collaboration in the United States. And the second is titled Characteristics Associated with Successful Foodborne Outbreak Investigations Involving United States Retail Food Establishments from 2014 to 2016. And the last one is Borrelia miyamotoi infection in immunocompromised man in California, 2021. Next slide. We've also highlighted a couple notes from the field publications, one on Campylobacter associated with consumption of raw water in Montana, and another on Shiga toxin producing E. coli linked to raw milk consumption. Next slide. You can also find web resources and announcements, including links to the Waterborne Disease Outbreak Investigation Toolkit, which now includes harmful algal blooms, and CDC's updated bird flu webpage. Next slide. Additional resources include NCEZID's 2022 Accomplishments Report that features various zoonotic and emerging infectious disease topics. Next slide. Some upcoming events and observances that may be of interest for this month. May is Lyme Disease Awareness Month. May 1st through 5th is Air Quality Awareness Week. May 5th is World Hand Hygiene Day. And then May 7th through 13th is National Pet Week. Next slide. And finally, we've shared some ongoing outbreaks, including Salmonella linked to flour, an outbreak of hepatitis A virus infections linked to frozen organic strawberries, and 2 listeria outbreaks, one for enoki mushrooms and the other where the food source is still unknown. Next slide. You can visit CDC's Healthy Pets, Healthy People website for a selected list of ongoing and past U.S. outbreaks of zoonotic diseases, and you can find details about ongoing U.S. outbreaks on the CDC websites linked from today's newsletter. Our next ZOHU call will take place on June 7th. Please continue to send presenter and topic suggestions for future presentations, as well as news from your organization to zohucall@cdc.gov. Next slide, please. You may submit questions at any time using Zoom's Q&A feature. Please include the topic or presenter's name. The Q&A session will follow the final presentation today if time permits. You may also email questions to today's presenters or zohucall@cdc.gov. We've included the presenter email addresses on this slide in the ZOHU Call webpage for today's webinar and in today's email newsletter. Next slide. Our first presentation, CDC's Vision for the Future of the National Wastewater Surveillance System, is from Dr. Amy Kirby. Please begin when you're ready.
Great, thank you. Yeah, so as Alexander said, my name is Amy Kirby. I am the program lead for the National Wastewater Surveillance System, NWSS, which we pronounce as NEWS. What I would like to do today is give you a little overview of where we are with NEWS implementation, and then spend most of my time talking about where we are headed in the future. Next slide, please. So when we established the NEWS system as part of the COVID response in 2020, even with that initial focus on COVID in a pandemic response, we knew that this system could be a surveillance platform for multiple pathogens and health issues. And it could be leveraged in a lot of different situations. So in addition to pandemic preparedness and response, which is what we saw for COVID, it can also be used for emergency response. So in the wake of something, a natural disaster like a flood, we often get worried about waterborne outbreaks like Shigella. If we have wastewater surveillance operating in those communities, you can do a short-term 3 or 4 month activation of those wastewater facilities to be able to look for Shigella in the wastewater and actively monitor whether or not you are having those outbreaks in the wake of disasters. So very good applications for emergency response. Equally, it can be used for emerging infections. So often when we see new emerging infections, things like enterovirus D68 or Candida auris, the first thing we know is the most severe manifestations that are showing up in the clinic and in the hospital. And it's very difficult to get information on community level infections and how that may be impacting what we're seeing in the clinic. Wastewater surveillance can be paired with those emerging infections clinical surveillance to understand what's going on out in the community that may not be showing up in the clinic. And then similarly, there's potential uses for bioterrorism. If we are aware of a pending threat or we know there has been an attack, we can, again, activate some portion of the system or the whole system to monitor the spread of that agent. Next slide. So the new system was established in September of 2020, again, as part of the COVID response. And has grown quite quickly since then. So this is our current implementation status. On the left is a map of all of the jurisdictions that are using CDC funds to support wastewater surveillance. So currently we have 46 states, 5 major cities, and 2 territories that are using CDC funds for wastewater surveillance. We've also established 2 NEWS centers of excellence. They are based in the Houston Department of Health and the Colorado Department of Health. Those centers of excellence are really tasked with moving forward the practice of wastewater surveillance for public health. And they are required to have partnerships with academic and utility partners so that we can fully represent all of the stakeholders in wastewater surveillance. The map on the right is an animated graphic showing the growth in the number of sites that are reporting data to CDC over time. We currently have over 152,000 wastewater samples represented in our data system, and that's coming from over 1,400 sites. So our state-led systems in the map on the left, then supplemented with a commercial testing contract that CDC manages, gets us to that 1,400 sites in all 50 states, 3 territories, and this is a bit dated. We're now up to 12 tribal communities. Collectively, all of those sites give us weekly data representing over 138 million people, so 40% of the US population. Next slide. The real heart of our system is our Decipher data dashboard. One of the unique aspects of wastewater surveillance is that what we measure is the concentration, in this case of SARS-CoV-2 viral RNA in wastewater, but that concentration is not comparable across jurisdictions because the way your wastewater system is set up and operated impacts the number that you get at the plant. So you can't compare, 100,000 genome copies per liter in community A to 100,000 genome copies in community B. So we use these metrics that are shown in this table. The percentiles and percent change metric are our primary outcomes. So percentiles is a relative measure. So looking at the latest data we have from a site, how does it compare to all of the measures that we have gotten from that same site? Is it in the highest 20% of concentrations we've ever measured, the lowest 20%, or somewhere in between? So where are we now? And then percent change is over the past 15 days. Are concentrations in this site trending up or trending down or stable? And how quickly are they changing? So between those two, you can see where are we now and where are we going in the near future. We also have a detection proportion metric, which is the most sensitive metric to detect reemergence of a pathogen in your community. So that's looking at of all of the samples in the past 2 weeks, what proportion of those have any detection at all, so are positive at any level. Unfortunately for COVID, almost all of our samples are positive at some level, so this detection proportion is almost always 100%. So not particularly useful for that, but I will show you for mpox, this is the metric that we're relying on. Next slide. So all of this data is available publicly on COVID Data Tracker. We have a wastewater surveillance page, which has all of our trend data. So what I'm showing you here is a aggregation of all of the data over time across the country and how wastewater has sort of risen and fallen with different surges. That data is updated daily. So as soon as it comes to us, it is analyzed, quality control, and then immediately pushed to data tracker. We also have a second COVID data tracker page, which provides variant data. So you can sequence SARS-CoV-2 out of wastewater and use that information to understand what variants of concern may be present and how that's changing. That data is available on the variant surveillance page. That page is updated weekly because sequencing just moves a little slower. All of that data is available publicly on data.cdc.gov, so it can be downloaded and anyone can use it. We have also in 2022 expanded to mpox as part of that response. There, as I said, concentrations are so low across the country, thankfully, that what we're relying on is detection proportion. So we currently have mpox data coming in from over 500 sites nationwide. And the vast majority of those, over 75% of them, have never had a detection, which is consistent with what we're seeing in the clinic. We do have some sites that are still a few that are having intermittent or consistent detections. What's really interesting here is we're now seeing that we are getting wastewater detections when we only know of one case in that community. We think we are capturing most, if not all, of the cases through clinical surveillance. And so the evidence is quite high that the wastewater system is in fact giving signals when a single case is present in the community, which is far more sensitive than we expected it to be at this level. That is also available, not on Data Tracker, that's on the mpox response page, and the data is also available publicly. Next slide. So where are we going from here? Next slide, please. So I did want to add this in here. We have sponsored a objective expert review of wastewater surveillance for public health by the National Academies of Sciences, Engineering, and Medicine. The preliminary report from that, the first stage, came out in January of this year, and I've linked it there. I'm not sure if you're going to have these slides. We can send it to you if you're interested, or you can search for it with NASM. Next slide. But their key findings are really summarized in this slide. So first, they found that wastewater surveillance is a valuable component of the pandemic response. And has helped to understand trends and variants. So that was good confirmation that we are on the right track with using this type of surveillance approach. I think the real key is that second bullet. So a national wastewater surveillance system should be equitable, so available in all communities, regardless of size, income, and demographics. It should be sustainable. So these don't work if you turn them on and off. That on-off switch is very costly. It's much better to leave these systems running all the time and activate them when needed. Should be integrated both vertically and horizontally. So we want it integrated from federal to state to local, and also across jurisdictions. So between states and between communities also needs to be integrated. It should be actionable. This is not data for data's sake. This is data for action, and flexible. So we want to be able to protect that ability to respond to something like mpox and quickly add a new target as public health needs change. They also emphasize that CDC should develop a transparent process for prioritizing new targets. And that's what I'm going to talk to you about for the rest of this talk, and then work to address privacy concerns. They also kindly emphasize that we need funding to do all of this, which should be obvious. Next slide. So as we think about expanding past COVID, we're thinking about that in a three-phase approach. So the first phase, which is where we are now, is expanding to what we're calling core surveillance targets. So these are common diseases that we really want as much robust surveillance data on as we can get. So things like influenza or antibiotic resistance or norovirus. So regular, consistent, cost-effective surveillance that's going to be ongoing for a long time. Once we have that in place, then we're going to think about phase two, and this is our emergency test portfolio. So what are those things that occur, are expected but sporadic? So Shigella is a good example there. Polio is another good example there. So things we want to have assays ready to go, fully validated, that we can deploy quickly. So phase two will be building that portfolio of emergency assays. And then phase three is just expanding that to a global vision. So looking out at what is out there in the world that could come to US shores and cause great disruption and great morbidity and mortality. And of those that are appropriate for wastewater surveillance, again, building that portfolio of assays that are ready to be deployed for these potential pandemic targets. So things there, Ebola is a good example there. Mpox would have been in this category, but it got here before we were quite ready for it. But luckily we were able to adapt quickly. Next slide. So as we think about evaluating a new wastewater target, these are the key questions that we're thinking through. So the first is that, is it actionable? Are there meaningful public health actions that can be taken at the community level? Wastewater data will never help you identify a case. It helps you protect your community. So this is truly public health response, not connected to individual medical care. So what are you going to do? Is there messaging to the public that is useful? Is there a vaccine campaign that could be provided? Can you provide resources to your hospitals, which is what's primarily the COVID data is being used for now? Or are there other uses? Is it worth messaging to clinicians in the area about these increases? So thinking through that from the front end. And then the other key is, can we even detect whatever this is in wastewater? The critical question is just a yes, no, can you detect it? But then once we get into really evaluating the data, there's more things we would like to know. What's the prevalence of fecal shedding? So of all of the people that are infected, what % of them are shedding pathogen in their wastewater? And that varies quite a bit from pathogen to pathogen. What's the magnitude? So how much does any one person shed? So that we can hopefully back calculate to cases. What's the duration of shedding for a person? How long is this signal gonna sort of linger in our system, wastewater system, from that single case that we detected? And finally, for our utility and laboratory partners, is what we're detecting in wastewater infectious, and do they have the appropriate PPE to protect them from this? Then we're moving on to, do we have assays that will work in wastewater? Often we're adapting clinical assays, and so the question is, do the recovery methods that we use for wastewater for SARS-CoV-2 and Mpox and other currently tested for pathogens, do those work for this new pathogen that we're evaluating? And probably most importantly, is the assay specific in wastewater? Wastewater is a very messy matrix, very literally so. And so we have to be very careful that what we're detecting is in fact what we think we're detecting. So what is the potential for false positives here? And then finally, what's the geographic distribution of cases? So if it really is just sporadic, likely travel associated, a single case in a sewer shed, it's unlikely we're going to be able to detect it. Mpox is an interesting challenge to that, but generally we think that single cases are not a good use of wastewater surveillance effort. But once you start having local transmission, then it's worth thinking about whether wastewater surveillance can be useful. And then that last piece about case ascertainment and timing, a good way to think about this is Ebola. Certainly Ebola sheds a lot through stool. We are quite sure that we could detect it readily in wastewater, but the case ascertainment rate for Ebola is virtually 100%. There is no asymptomatic carriage. People get sick very quickly. It's a very obvious clinical manifestation. They're going to go to the hospital and they're going to get diagnosed correctly within a fairly short order of time. And so we're catching all of the cases, we're catching them fairly quickly. Wastewater data is probably going to be behind that and not add to anything for Ebola. So thinking about that ascertainment rate and timing is really antibiotic resistance is the total opposite of that. We know we're only seeing a small percentage of the resistance that's carried in a community, and we often don't find it for months, if not years, after a person has been carrying it. So it's the total opposite of Ebola in that case. Next slide. So bringing all of that together, we are moving forward with the first implementation of the news panel for core targets. And this is what we have prioritized for this round. So we have normalization and process control. So pepper mild model virus and crass phage are viruses that are unique to human feces. And so we can measure those in wastewater as an indicator of how much of that wastewater is human feces versus all of the other things that can be in wastewater. So it's a good way to normalize to human contribution into the wastewater system. And then bovine coronavirus is our process control. So you spike that into your raw wastewater sample and measure how much you get out at the end, and it gives you how much of your targets you're recovering. So if you're only recovering 20%, which is pretty common for environmental tests, then you know that you're underestimating your pathogens by that much, and you can adjust your data. For the actual targets, we have an antibiotic resistance panel. Here we're focused on the genes that are most concerning in the clinic. So carbapentamases, extended spectrum beta-lactamases, colistin resistance, and vancomycin resistance. We've also expanded our pathogen targets. So there's a respiratory panel that's of course still SARS-CoV-2, but adding influenza A and B and respiratory syncytial virus. We have a small enterics panel. So adenovirus 4041, Shiga toxin producing E. coli, Campylobacter, and norovirus G1 and G2, which are the primarily human associated noroviruses. And then there's an emerging pathogens panel, which is Candida auris, the fungal pathogen, and Mpox. Our plan is that this panel will be reviewed every year to make sure that we are still prioritizing the right targets and that the assays are still aligned with the molecular epidemiology of the pathogens that we're interested in. So we expect this, all the assays are in validation right now, and we're hoping to be able to pilot them with the News Centers of Excellence. This is a bit dated slide, so we're probably looking at late 2023 at this point. And pilot there, assuming we can get all of the kinks rolled out or worked out, rolling it out to the full system in 2024. And of course, all of this data will also be available publicly in real time because that's one of the key tenets of the news system. Next slide. So what are we focused on other than that core expansion? We want to continue extending coverage. About 80% of US households are on sewer systems. I don't know that we'll be able to get fully to 80%. We can certainly get closer to that than we are now, which is 40%. We want to improve our metrics. We would really love to be able to take wastewater data and convert that to a case estimate. So what is the prevalence in a community? Right now, we can't do that, but we're hoping with more research, we will be able to get there with some of our pathogens. Thinking carefully about how do we prioritize sites and timing of sampling as we move into multiple targets. For COVID, we want every site we can get sampling at least twice a week. That is overkill for something like antimicrobial resistance. So what's the right sampling frame for something like that? We're always interested in improved methods and workflow. We still have big questions about the impact of vaccination and variants on fecal shedding. Certainly the impacts have not been as dramatic as we thought they might be, but there probably are some differences in shedding in breakthrough cases in vaccinated people and cases with different variants. We just don't have enough data to know. We're always improving data submission and lowering that bar so that we can get data into CDC quickly and with minimal burden on our health departments. And then finally, I want to note that there's a lot of effort around ethical transparency for wastewater surveillance. This is not clinical testing. We do not fall under IRB, for example, or human subjects research, but it is environmental testing for public health. And so we recognize that there are ethical issues primarily around consent, privacy, equity, and stigma. And so we are working with the CDC Public Health Ethics Work Group to do a full ethics evaluation and develop a framework that we can work under so that our implementing partners and the public know exactly how we are using this data and what is within and outside of the bounds for this data. Next slide. And so that's my last slide. I'll just say if you have questions, feel free to reach out to us at nwss@cdc.gov or through my email address. That's fine too. You can also get more information and resources at cdc.gov/news. And I will turn it to our next speaker.
Thank you so much. Our next speaker is Melissa Crutchmer. She will present on the first evidence of locally acquired dengue virus infection in Maricopa County. Please begin when you're ready.
Thank you. I am the epidemiologist in Maricopa County, Arizona, and I will provide a high-level overview of the dengue virus, followed by an in-depth look into what happened last November here. Next slide. Dengue virus belongs to the flavivirus family, which includes other viruses like West Nile and St. Louis encephalitis. There are 4 serotypes circulating globally, with predominant serotypes varying geographically. Each serotype is capable of causing illness without offering cross-protection to the other groups. Next slide. Transmission is primarily through mosquito bites. Here in Maricopa County, we are concerned about the Aedes aegypti mosquito. Next slide. Only about 25% of people may develop symptoms if infected. The severity of symptoms is based on age, number of prior dengue infections, and comorbidities. The incubation time is commonly 5 to 7 days. Most people are considered infectious until about 7 days from symptom onset. You'll notice in this graphic that people are viremic 2 days prior to onset. So asymptomatic individuals are capable of spreading the virus to mosquitoes. Next slide. The virus is present worldwide, primarily in tropical and subtropical areas. There are an estimated 100 million cases per year, and the continental US has experienced occasional dengue outbreaks. Most of these have been relatively small and limited to small areas. Next slide. Specific to our story in 2022, Cuba, circled in yellow, was having a large outbreak. Next slide. About 95% of people who develop symptoms will show signs of dengue, mild dengue. Symptoms primarily consist of a high fever, along with at least one of the other symptoms on the screen. Most commonly, we hear from people that they've had a severe headache and a rash. There is severe dengue that is more likely associated with subsequent infection and requires immediate medical care at a clinic or a hospital. Next slide. There is no specific treatment for dengue virus infection. Only supportive measures like rest and fluids can help manage symptoms. Due to the risk of bleeding associated with infection, certain medications should be avoided if dengue infection is either confirmed or even suspected. Proper treatment can reduce case fatality to less than 1%. Next slide. Prevention is protect yourself. Take efforts to reduce mosquito exposure as much as possible, like wearing mosquito repellents, removing standing water, and repairing screens so mosquitoes may not enter the home. The FDA did approve a vaccine called Dengvaxia in January 2022. Only children 9 to 16 years of age and with evidence of prior dengue infection and living in endemic areas should get vaccinated. Next slide. The arboviral diseases we see here in Maricopa County are primarily West Nile virus and St. Louis encephalitis. So our mosquito surveillance is based on the Culex species of mosquitoes. We do targeted dengue testing around known travel-related cases, using our information from our interviews to guide the mosquito surveillance. In 2016, we partnered with our environmental control, vector control group and our state health department to draft and test a response plan to local transmission of a disease transmitted by Aedes aegypti. We identified triggers on both the human and mosquito side and discussed what our response would look like. Next slide. Even though dengue is not endemic here, we do receive occasional reports associated with travel to endemic areas, averaging about 7 cases per year. We'll interview the patient, provide education, and ask if vector control can place a trap on their property to make sure local mosquitoes did not pick up the virus. So our investigation started like any other, when on November 7th, we received notification from the state health department that a known case had tested positive for dengue virus 3. Next slide. The individual reported international travel on October 12th for 4 hours. Dengue-like symptoms started about a week later on the 19th, and we were informed by the state health department that dengue virus 3 was not known to be circulating in the travel area. Due to the short duration of the trip and the serotype, we decided to reach out to our vector control group to make a special request and do retrospective dengue virus RT-PCR testing near the home of the patient. They pulled all of the female Aedes aegypti that were trapped within 5 miles of the residence, and testing was done backwards for 2 incubations, or about 1 month. 21 mosquito pools were tested for the virus. Next slide. During this, they found 1 pool test positive for dengue virus 3, the same serotype as patient A. Our response was initiated immediately. Next slide. Getting back to our plan, we had just reached 2 triggers. 1 human infection with suspicion for local transmission, and also a dengue virus positive mosquito. So we started rolling with the theory that patient A acquired dengue virus infection in Maricopa County. This was later supported by whole genome sequencing by CDC Dengue Branch. They determined that patient A and pool A had closely related dengue virus 3 strains, not known to be circulating in the travel region and suggesting local transmission. Next slide. On November 10th, our incident command structure was activated to allow for easier communication and coordination with our partners. Human and mosquito enhanced surveillance to identify dengue virus was initiated. Next slide. Our public health group reviewed prior reports of potential arboviral infection to make sure there was no concern for local transmission previously. During the response, we also changed some of our investigation processes to include prioritizing dengue reports and investigating everything, both positive and negative lab results. No evidence of local transition was identified in retrospective review, nor in the investigations received during the response period. Next slide. Public-facing efforts include reaching out to partners to provide awareness and media so that the public would be informed. These are this is our press release on the bottom right and how it was translated into print on the other 2 images. Next slide. Our vector control group expanded their retrospective testing to the entire county going back to September. An additional 4,299 mosquito pools across the county tested negative for a total of 4,320 negative pools and not 1 positive. Going forward, they did expand testing to any pool containing female Aedes aegypti throughout the county. An additional 624 mosquito pools were negative for dengue virus. Next slide. This is the same information, but in a table form, emphasizing that Maricopa County Vector Control tested the entire county, as noted in yellow, resulting in 4,944 Aedes aegypti mosquito pools being tested for dengue, noted in teal, and we found 1 dengue positive pool, noted in orange. Next slide. Field teams were deployed November 17th through the 19th. They consisted of public health staff to interview residents and collect blood, along with vector control staff to conduct backyard assessments. The state health department assisted in coordinating serology testing at the state lab. Next slide. Public health focused on identifying other infected individuals through a survey and offering dengue testing in the home. Vector control offered assessments of the residents' yards, focusing on identifying and removing potential mosquito breeding sites. Due to the colder weather, treatments aimed at reducing the mosquito population were not done, but would be considered for other outbreaks. Next slide. This is a simulated area. I want to make that clear. This is not where events took place. As for our plan and prior CDC Zika-based guidance, A 150-meter perimeter was identified around any trigger. Various types of maps were used to determine the landscape of the area and how many parcels were contained within the perimeters in total. Based on our boots on the ground exercise in 2017, we had an idea about how many households could be completed per 10-hour shift. So that did guide the number of teams and how many days we'd be in the field. Next slide. After all that mapping and math, 5 field teams were assigned to certain sections of the affected areas. The number of available phlebotomists varied on the days. Next slide. Again, this is a simulated area. This is not where events took place. Anything touching the perimeters were included and teams were assigned to equally sized areas. Next slide. Overall, we had 5 teams in the field over 2.5 days that approached 241 households. Regarding the environmental assessments, the bottom right slide, 72 or 30 households consented to vector control to take a look in their backyard. Next slide. Breeding sources were identified with planters being the predominant source seen. Next slide. Some pictures provided by vector control on the slide. Remember, this is mid-November when temperatures were getting below 50 degrees Fahrenheit, and we still had evidence of mosquitoes and breeding sites. Next slide. Regarding interviews, 59 households representing 73 persons were interviewed and had dengue virus testing done on them for 53 of the 73 participants. Next slide. So 53 people consented to dengue virus testing. Which type of testing was based on if they had onset of symptoms in the 2 weeks prior to their interview. Next slide. 12 respondents reported recent dengue-like symptoms. As per dengue testing guidance, PCR was done and all were PCR negative. The specimens were then reflexed to IgM and they were all IgM negative as well. Next slide. 41 people did not have symptoms in the prior 2 weeks, so IgM testing was done to look for evidence of recent infection. One person had confirmed dengue virus 3 by PRNT and reported no travel in the 2 weeks prior to symptom onset. Environmental assessment of this residence identified Aedes aegypti mosquitoes and breeding sites. Mosquitoes collected in a BG sentinel trap were PCR negative, dengue PCR negative at the lab. Next slide. This is just an example of the schematic that we designed in collaboration with CDC and the State Health Department prior to the field team deployment. Next slide. Looking at the case that was found in our door-to-door efforts, it is important to note that case B's onset was 2 months prior to our original case, suggesting a potential local transmission range in Maricopa County of late July to October. We have been going out to our providers to provide situational awareness and also providing education on dengue, posing the question to them on if they thought they had any compatible cases in that time frame. Next slide. The outbreak ended January 4th, 2023, after more than 45 days without newly locally acquired cases as per prior Zika-related guidance. Next slide. Overall, we feel that the multi-agency collaboration between our preparedness group, epidemiology, vector control, city officials, and the city fire department were exemplary. However, when teams arrived in the field, there was some confusion as to who would be approaching the helm and conducting interviews. As well, when approaching the affected areas, our teams came across a variety of structures that were not well detailed in our preliminary mapping efforts. Sending a team ahead of time to survey the area would have been beneficial. Next slide. In summary, our coordinated efforts identified the first locally acquired dengue virus infection in our county. Our established partnerships helped us to move quickly and efficiently, and we are planning on enhancing surveillance to prevent this from happening again. Next slide. These are just an example of the number of people needed to make this happen. This is just the public health group with our preparedness and field teams and communications group. Next slide. This is vector control and their field teams and laboratory staff and leadership that were needed. Next slide. And then these were all the groups that supported us through their knowledge and experience. The state Arizona Department of Health Services, Centers for Disease Control, and also Florida, we consulted for the local perspective as well. Next slide. And that is all I have.
Thank you so much. Our final presentation today is on farm workers and One Health issues, risks, burdens, and strategies. Bethany, please begin when you're ready.
Hi, y'all. It's a pleasure to be here with you guys this afternoon. My name is Bethany Bogas-Alcauter. I'm an occupational epidemiologist and a program director at the National Center for Farm Worker Health. We're based in Texas, and we've been working on farm worker health issues for about 50 years. And I'm excited to talk about this topic because I conceptualize One Health really as the way, sort of thinking about how humans are a part of nature, and that's a really old scientific idea. and it's one that farm workers know very well. You can advance the slide. So just briefly, I wanted to talk a little bit about who farm workers are. Many times I meet folks who have maybe outdated or an inaccurate idea of who is working on farms in the US today. So many people have an idea of, a nuclear family that's working on land that they own, and that's not really the case. Most folks who work on farms in the US do not own the land, and the majority come from Mexico or Central America. You can advance that slide. So we think there are around 2.5 million farm workers, and that includes folks working in both crops and with animals. It's a little hard to estimate because a lot of farm workers move around and hold more than one job. About half are undocumented. They don't have authorization to work or live in the US. About 1 in 4 are living in overcrowded housing, and the majority of farm workers are earning poverty level wages. Go ahead. Farm workers in the US are extremely diverse. I travel around to a lot of different places, and I will meet folks from Haiti and South Africa, in addition to many Latin American countries. And there's many aspects, many factors in diversity, but linguistic diversity is one good indicator of that. So a lot of our efforts and interviews with farm workers in different places has found that farm workers are speaking many, many different languages, and a large proportion of farm workers are native. Their ancestors have been in the Americas for thousands of years. And I often meet farm workers who speak those very ancient languages today. So it's a beautiful thing, but it also presents some challenges for worker health and safety. Go ahead. So just briefly, we're going to talk about two things that sort of connect farm workers to One Health issues. One of those things is their vulnerabilities. And I could talk for a long time about that, but there's 3 big ones that I want you to remember. So one is just that farm workers have very low incomes, and this means that they often aren't able to afford adequate housing. It makes it really difficult to access healthcare in this country, since the majority of farm workers don't have health insurance. And it also means that they often work very long hours. So I've met many farm workers that work 80 to 100 hours a week, which just means they have a really long exposure time to all the health threats in the workplace. And that can include insects, being around livestock and wildlife, natural disasters, temperature extremes, and many other environmental threats. The biggest vulnerability that farm workers have is really just an exclusion from safety nets. And some of that is sort of baked into the system. So for example, people who work in the agricultural industry are excluded from a lot of labor protections that workers in other industries have. And then some of them are just sort of logistic. So for example, many farm workers live in very isolated areas. There's no public transportation. They often don't have personal transportation. So it just becomes very difficult to access any safety nets and healthcare and things like that. Go ahead. A few of their risks, obviously the majority of farm workers are outside all day long. So they're at a greater risk for hypothermia as well as hyperthermia and a number of emerging heat-related illnesses like chronic kidney disease of unknown origin. I'm seeing more and more rhabdomyolysis. Workers are working so hard and it's so hot that their muscle tissue is breaking down. And then many farm workers, especially in certain parts of the country, are exposed to a lot of natural disasters. And this really hits them hard because they feel it in the workplace and they feel it at home. And then they're often losing income on top of that. So farm workers are very sensitive to the impact of natural disasters. Go ahead. Another big one that we've been looking at more closely in partnership with the CDC is vector-borne diseases. So because farm workers often immigrate from regions where there is a really high prevalence of vector-borne diseases, like Chagas, they may be at higher risk. They also may be experiencing them here while working in the US. So we're pretty concerned about a number of tick-borne diseases, mosquito-borne diseases. Chagas is a big one in the South, and there's a host of other neglected tropical diseases that farm workers may be experiencing, but there isn't really a lot of research data on this topic in the US in this population. Livestock workers have a very high risk of zoonotic diseases, right? They're around animals, 12, 14 hours a day, 7 days a week. So they're kind of a canary in the coal mine often for the evolution of new viruses and just exposure to things that we know about. I'll say anecdotally myself, I used to raise chickens. I got sick with Campylobacter, and that was not fun. And I speak English and have access to healthcare whenever I need it. So I can only imagine how much worse it is for some other folks. Bovine tuberculosis is a big concern. We've seen tuberculosis go back and forth between dairy workers and cows on some dairies in Texas and some other places. Q fever and influenza obviously are also major concerns. We really believe that farm workers should be a high priority in this field. And I think more and more folks are becoming aware of it. And it's really because, like I said, they're sort of a barometer. They're a canary in the coal mine for a lot of these issues because they have so much exposure time to nature, whether that's animals or climate or anything else. And then just because of all these social inequities they face, they feel the effects of those health risks more severely than a lot of other groups. This also makes it a little difficult to track, which I'll talk about in a minute, but it just makes it a really critical population to look at. It's also critical to global health because so many of them are, coming from other countries. And we sort of have a responsibility, frankly, because of our history in this country of environmental injustice to Black, Indigenous, and people of color. So it's sort of a moral obligation to help this population mitigate these risks. Go ahead. Sorry, I tricked you there with the slide pause. One strategy that we think is really strong, and I'll talk about in a minute, that we've sort of learned about in the pandemic, is really a heavy emphasis on local collaborations among partners. So farm workers are often deemed as very hard to reach because of a number of structural inequities, their isolation, all those things I mentioned before. So we found that they really are very effectively reached by working with local trusted leaders. So that might be advocacy organizations, that might be clinicians. Sometimes that means working with the employer or the labor contractor. There's just a host of partners that need to be brought together in order to address health issues among farm workers. Go ahead. I mentioned this before. Another key strategy that we feel pretty strongly about is strengthening surveillance in this population, surveillance of disease, right? And our ability to respond. So again, we've seen that local responses are really important, but something we've worked on really hard is increasing our ability to detect sort of these inequities, because farm workers often are not accessing healthcare systems. And so they're not going to pop up in clinician reports or things like that. You really have to build the capacity of those local trusted leaders to be able to find the issues that farm workers are experiencing and then bring them up to local public health officials. Go ahead. So part of that we've worked on in collaboration with the CDC has been focused on exactly these strategies and issues. So we've worked with them on a cooperative agreement for the last few years. It's overseen by the Division of Global Migration and Quarantine. And what we've done is really sort of build out a suite of tools and built the capacity of local farm worker serving organizations to do outreach and to do education around infectious disease with farm workers in their communities. And just 27 small organizations are able to reach and educate about 500,000 farm workers every year. And they're using different data-driven tools that we've provided, including a data dashboard around farm labor. We've conducted a lot of surveys with farm workers to help communities understand inequities and pull together other resources for them as well. So that's all I've got. I wanted to save a few minutes for question and answer, and my email is up there on the slide. Thank you.
Thank you so much to all of our presenters today. Links to resources from each presentation are available on our website at cdc.gov/onehealth/2023/may.html. We have time for just a few questions. So for wastewater, are there opportunities or plans to link the wastewater surveillance system to the National Veterinary Diagnostic Lab Systems? Amy, I'll turn that to you.
We have just started those discussions, so I think that's a really interesting question. Linking to systems like that really is a problem of jurisdictional boundaries. So our unit of geographic measure is sewer sheds, which don't overlap with counties or cities or anything that most of our other surveillance systems are with. So that's where we have the biggest challenge. But this is definitely something that we're thinking about, especially as we expand to things that have more of a zoonotic potential. So influenza, AR, things like that. We want to really amplify the One Health possibilities here.
Thank you. For dengue, what is the best timely data source to see what strains are circulating in various countries? Melissa, I'll turn that to you.
Yeah, thank you. So what we used for us, we're primarily concerned with Mexico with for our residents. It was the PAHO website that was helpful in knowing. I don't know how timely it is, but that's the source we used.
Okay, thank you. And Bethany, are farm workers monitored for antimicrobial resistance due to their interfacing with farm animals?
To my knowledge, there isn't any project going on like that right now. I mean, it's possible there is, but I have not heard of anything.
Okay, and then one other on farm workers. Is the incidence of bovine TB due to direct acquisition from cattle on the farm, or is it more likely from consumption of unpasteurized milk products?
The research on that is still kind of ongoing, but the studies that I've seen, it's more just during the milking process and not really consuming unpasteurized milk.
Okay, thank you. And then we'll try to do one more for wastewater and dengue. For wastewater, can you describe the reporting system for how sites send data into the surveillance system?
Sure. So wastewater is collected by utilities. It's then sent to the laboratory for testing. That raw data is then provided to health departments. And they upload it either through a manual like CSV upload into Decipher or through API connection. And then the Decipher system has all of the analytics and quality checks built in. And so generally almost real time, you get the results back, but occasionally there's a lag of 20 to 30 minutes. And then the results are available in Decipher for health departments to use. And that night at about 8 p.m., they get pushed to COVID data tracker.
Thank you. And then the last one for Melissa is dengue surveillance and sampling influenced by recent or seasonal weather changes such as rainfall patterns?
So in Maricopa County, where it's not endemic, it's really our surveillance is based on, you need to know where the virus is and where that's how we know where the virus is when people are testing positive. We consulted with CDC evaluating our current surveillance, and they did emphasize you need to know where the virus is. So the partnership between public health and vector control is very important to be able to kind of detect these sort of things.
Okay, great. Thank you all so much. Let's see, next slide, please. So we've included presenter email addresses on the previous slide on the ZOHU Call webpage for today's webinar and in today's email newsletter. If you have any additional questions, a video recording of today's webinar will be posted on the May ZOHU webpage within 30 days. Please join us for the next ZOHU Call on June 7th, and thank you for your participation. And thanks again to all of our wonderful speakers. This ends today's webinar.